improvement quite quickly. Thank you so much, Sam. So we've recorded, so just remember that when you do comment. Okay, so we're gonna give over to Crystal, who is our CLI lead from Anova. So she is very well versed in this topic. So she's gonna give us a 20-minute presentation. Then we'll hand over to Mr. Ihshan Noordin, who is from NHLS. So we're quite excited to hear from him. He's going to do a bit of a about a 20-minute presentation as well. And then that will be it. That will then give us some time left just to reflect on the past 7 sessions. Like Sam will help us with that. But it will also be an opportunity if you do have any questions, both on this session, specifically thinking about the clinical laboratory interface, but also if you have any questions regarding patient management for viral loads related to anything that we've discussed over the 7 weeks. So if you do think of questions through the presentations, please pop them into the questions so long. We can have some people starting to respond to them, but we can also discuss them after our presentations. Perfect. Anything from my team, house rules wise, happiness? Perfect. Then I will hand over to Crystal.
Thanks, Elsie. Good afternoon, everyone, and just thanks for the initiative in terms of including CLI in your echo sessions, because I do think it's quite critical. So I will be presenting on the CLI or clinical lab considerations, and specifically around viral loads. So just to give you, some background, because I know a lot of people ask what is CLI. So just for background purpose, so obviously the CLI program, it has been identified by the National Department of Health, as well as USAID, who's our funder, as a needing focus, specifically in the Western Cape. So we as Anova, and we also have other partners, SEED, that are funded for to support the department in terms of the CLI activities. And then obviously the CLI program, we specifically look at the first 95. It's obviously got a HAS focus. So we look at the first 95 that looks at the quality of HIV testing. And then the third 95 that specifically focuses on the viral load suppression, obviously also coverage as well. And obviously that is why this is so fit to actually present CLI. So basically we do health system strengthening, and we've actually realized that, there is a need in terms of, strengthening processes within facilities, around quality of HIV rapid testing, results interpretation, as well as, result management processes, and also getting or reducing our specimen rejections through clinical errors, and ensuring that viral load monitoring process is, in place. And maybe just, for the purpose of the presentation, that our targets for CLI, so we need to ensure that all viral loads or rejection rates, not only viral loads, but all rejection rates need to be below 3%. So this is specifically viral load, CD4, PCR, and TB rejection. So that is basically what we are, aiming. And obviously our interventions will be directed in terms of where the high rejections is. So I always think it's always good to just start with, a data slide to just, inform why we're doing this, why it's important. So on your left-hand side, we looked in terms of what the viral load performance is, and specifically for our Q3, so that is from April to June. And I think obviously for a lot of you see that will be the sub-district breakdown. So you will see that our viral load coverage, it ranges between 80 and 89%. So that is only viral load coverage. Our suppression rate, obviously, it's above 90, and you can see for most of the sub-district, I think for all of the sub-districts, it is above 90%, which is, I mean, even 94, 95, 96%, which is great. But I think ultimately what we need to improve is obviously our viral load coverage, because we need to get that also above 90, because basically if patients on ART, we need to ensure that, viral loads are being done at the correct intervals. But then, so the question was, does viral load rejections actually impact, the viral load coverage? Is our viral load coverage low because of rejections? And you can actually see on your right-hand side, there's also a sub-district breakdown where we looked at, in terms of what is our viral load rejection rate. And like I said, we need to keep it obviously less than 3. I think it's only one sub-district that are doing quite well, that are less than 3%. And then obviously all the other sub-districts are above our, 3% threshold. So obviously that is, I think some of the things that we need to actually investigate to find out if this is due to, our viral load coverage low due to viral load rejection, obviously how that. So when we look at, what is the CLI interface and specifically, there's obviously different phases where errors can occur. So when we look at the pre-analytical phase, so that's obviously when the patient, it starts with ordering of the specimen collection material, and then the actual collection sample from the patient, and then it goes on to where you actually label the specimen, package it, store it, the actual documentation, and then obviously preparing the sample for collection. And then obviously the courier will come and collect the sample, then goes to your analytical phase that specifically look at lab processes. And then for post-analytical phase, so that's obviously around, the actual management of the results. So you will see there's a result delivery to the facility, then get filed, and then the patient management. And I think obviously within the CLI value chain, we are picking up that most of the errors occur in the pre-analytical phase, because it's mostly, in terms of how the sample are actually collected. And the second biggest, it's around, I would say it's result management, because I think, when we look at the highest, what is the contributing factor in terms of high viral load rejections, it's most of the time it's EGK. And I mean, when we refer to EGK, it's basically clinicians requesting bloods out of guidelines or not applying the EGK codes, etc. So there's various factors, but obviously you can see that, I mean, and I think Irshan, my colleague, will also present in terms of, the actual rejections that we do get. But I just want to highlight here that it's mostly in the pre-analytical phase in terms of how the sample, and then you will see how the post-analytical phase actually also can contribute to errors. And then we looked at, and I think obviously, like I said, us as Anova, we funded in terms of supporting the CLI program. So we looked at how do we actually address the what would the pre-analytical support for specifically around viral load phlebotomy to reduce rejections look like. And I think this is what I regard as a toolbox. You will see on your top left is we created a job aid that basically say don't get rejected. And obviously Dr. Els is very creative, so she assisted us with creating this colorful, and I think it's also been well perceived at facilities in terms of, so when we say don't get rejected, what are the elements that actually can contribute to low rejections or no rejections. And I think one of the things that we get a lot is the prevent hemolysis. So there's just a few steps. And then gatekeeping, like I said, that is really what we're struggling with. And then also the order of draw that can also impact, that can also contribute. And then we've, other tools that is quite important when we look at, reducing rejections, because the primary or the PHC lab handbook is basically a step-by-step guide. So it will take you right from how to collect, what bloods to take, how to store samples, right up until how you actually, when the courier come and collect, and up until the completion of the inform. So it's really a good guide. And I mean, every blood room should essentially have a PHC lab handbook, because it's really great. And I mean, it really, you can easily go. And obviously the EGK circular, that is also quite useful, because this will guide clinicians in terms of when to do bloods, at what interval. So there's your MRI that speaks to all the tests. And then also what's also very important is obviously the completion of the N1 form and the N3 form that basically looks at stock management, because we also encourage clinicians that, they should not overstock or understock, and obviously also considering like FIFO, and ensuring that they're not using expired samples, because that ultimately will also cause a rejection if they are. And then this is a very generic, so I mean, result management process, and I know obviously it differ. But like I said, we also realize with, doing facility visit and support, that there's a big need in terms of, post-analytical support, and that's around viral load result management. And I always say, when a clinician take blood, I mean, there's a reason why we are taking the sample. So I almost say it's criminal if you don't actually follow up on the result, or actually see what the result, and obviously action it accordingly. So it always starts with obviously the blood collection. It can either be, and I know specifically in the city facilities, they do it in their consultation, and for a lot of facilities, they also have the blood room. It goes through the courier, or it goes via courier to NHIS for processing. And then there's printed results from NHIS that are delivered back to the facility. But I know a lot of facilities have switched off, because most of the time it's just compiling at the central point. But this is just referring to facilities that are still getting. And I think obviously now with the NHIS data breach or the hack, I mean, facilities are not getting any results at all, or paper, talking about the hard copies. So normally the result would be received at the central point for distribution. Then there's a portfolio holder or a champion that would basically sort the results, flag abnormal results, and then obviously patients are being recalled, and then then viral load results are being captured onto the health information session at your next visit. So this is basically just some, but like I said, I know it's difficult, but I mean, we should be following up on the results. And another way that we can action this is specifically what we've actually been doing, what have been really helpful in terms of the result for action report. So we are really encouraging, and we've really been working with a lot of facilities in terms of getting them registered onto this, platform, because specifically for abnormal results and, urgent results that needs actioning quicker. So I mean, it's just a matter of you going on to, if you are a registered nurse or a doctor, I mean, obviously you are able to register. So you go onto the NICD website, you then obviously there's a self-registration tab, or the M&E reporting tab, where you then, follow the self-registration number. And then obviously as a new user, you will have to take, obviously go through the process, because it does require some personal information, and obviously the SANC number if you're a nurse, and obviously for doctors there's also the your registration number. And then obviously you can then, once you've completed that step, you can then obviously go on to what reports would you like. So obviously there's a district report, there's your facility report, even sub-district report. So currently it's limited to CD4, viral loads, ELISAs, your PCRs, Yeah, so that's basically the reports. And then obviously once you are registered and all your reports, because it obviously needs to go via approval process. So when NICD approve your requests for obviously certain reports, I know there's also, sorry, a CRAG report, but then obviously you will get a email notification where you're then able to obviously with your login details access a report, download, and obviously action accordingly. Then I think obviously what we've realized now with the NHLS or HAC, where we could not access any blood results. I think for the Western Cape, we've been really fortunate in terms of having a system um, that we could actually use in terms of getting results. And also it's like an electronic patient where you can actually see patient details, and it also basically links to JAC, NHLS, and I think that's actually quite great. So I mean, but obviously it's a great system, but only when you have access. So I think obviously what we've learned also now with not having or not being able to access trachea, that this was the another way of actually getting into patients' results, etc. But obviously there is a registration process that you need to go through, and then obviously it will take you, once you've received your login details, you will then be able to just to get into patient information or patient shirts that you can conduct. And then obviously if you're a clinician, it will then give you an option. So what they normally probe you to say, please select your reason for accessing patient folders. So obviously if you are a clinician, you will obviously say clinical care, but there's also other options. And then obviously once you've selected, then like I said, we have different health information systems that basically feeds, so if you enter a patient folder number, the system will then triangulate, from different systems for this specific patient, because if there been any hospitalizations, if there was any request for bloods, even for medication, it will then pick up and it will actually populate the complete, episodes, even for the patient encounters or appointments or medicine. So like I said, it's really great because, I mean, you can then, there's an opportunity, you can't miss any critical information of the patient. But I think in terms of the lab, which I think is really great, when you go on to, when you're on SPV and you actually click on the graphical viewer, you're then able to see when the patient was diagnosed, specifically HIV positive. You can actually, there's a graphical view of, the patient's CD4 count while, since the diagnosis. There's also the viral load, what the viral load has been while the patient is on treatment, and then also the medication. So I think obviously from a clinical perspective, this is great. And like I said, you are able to, go back and just review the patient information, and then obviously plan, your clinical management for the patient. And like I said, the CLI program aims actually at improving patient outcomes ultimately. And I think that is basically it. Are we taking questions now, or are we taking it at the end of Sean's presentation? Thanks.
Thank you so much, Crystal. That was very, very interesting and definitely a different view to viral load management than compared to what we've been doing for 6 weeks. And very well done on time management. You have bought us 3 minutes. So if there's any questions from the audience first, that's critical. Otherwise, we'll take most of our questions after Irshan's presentation. Irshan, you're welcome if you have a question or a comment.
I'm sorry, I have a comment. Just in terms of people accessing results via WebView, I find that I have found that a lot of people have lost their password, and they tend to use the data clock's password or someone else in the clinic's password. Now, viral loads are confidential results, and sometimes when a data clock applies for access to WebView to look up results, they aren't given access to these confidential results. So only those persons who are able to see the result have access to the result. So what happens is the doctor loses or forgets their password. They go to the data clock and say, "Can I use your password?" They want to access the results, and they see they can't see the results on the patients. And then they call the lab. They want to know why the test hasn't been done. But really, it's just a case of using someone else's password that doesn't have access to these confidential results. So I would suggest that people use their own passwords. If these have perhaps expired or they've lost them or whatever they've done with them, write to me and we can get them renewed for you so that you use your own password. Thanks.
Thank you. That's very valuable information, and I think key to a lot of us on this call. Any other questions from the audience? Otherwise, we'll take them after Sean. Okay, perfect. Thank you, Sean. Clearly, you're going to share a lot of practical wisdom for us from the NHLS, which we're excited for. You're welcome to jump in.
Let me unmute first. Let me go share screen, share entire screen, share entire screen, share, and then share my presentation. And now, Elsie, can you tell me, can you see my presentation?
I can. You can put it in presenter mode as well.
Into display mode. Okay, so good afternoon, everybody. Good afternoon. I am Ihsan Noordin. I work at the NHLS at Greenpoint, and thanks for joining us for this talk this afternoon. I want to talk a little bit about rejection of samples, and for this afternoon's meeting around viral loads. So on a monthly basis at the lab, we get what's called a rejection report, and we share this with various people, and we share it with Anova as well. And we can see of the tests that you have sent to the lab, and the samples are either, as it shows here on the screen, insufficient, or the information doesn't match, or it's not labeled. We would then reject those specimens. So typically, we took the report and we filtered on the viral loads, and these were the kind of rejections that we saw were quite common, requiring a separate specimen, unsuitable, insufficient. And we can come back to this list and perhaps talk to it again. But I wanted to start with, and I know Crystal mentioned it earlier, one of the more common reasons for rejection of viral load tests is gatekeeping. So what is gatekeeping? Excuse me. Gatekeeping, as it says, is a policy by the Department of Health to reduce the number of inappropriate tests being ordered, right? So essentially what that means is you could ask, they don't want you to ask for a test on a patient today and then ask the same test tomorrow and the same test the next day. It serves no clinical purpose, and so it is with viral loads. So the time period for a viral load that you can ask for today and when can you ask for it again would be in 3 months' time. If you ask for it before the 3 months' time, we are going to reject it. And it's an electronic gatekeeping. There's nobody there making a decision. Our LIS lab information system looks at the date we received one today, and we look when on this patient with this folder number and so on and so forth. When was the last time we did it? And it was done 2 months ago. It gets rejected. So you have to look very carefully before you ask for the viral load. You have to have access, of course, to WebView, and then you'd have to check to see when last the patient's viral load was done, and then ask for the test to be done based on those periods. The other cost-saving measures that the Department of Health has introduced is for you to consider carefully when you ask tests. Do you need the test? Is it clinically indicated? Will assist with the diagnosis? And then also to ask for not ask for these long profiles like UNE and an LFT. And LFT is about 10 or 12 tests, I think, with all the liver enzymes and bilirubins and calciums and so on. You've got to hone in on taking good clinical history and then asking for the tests that you think are specific to make a diagnosis. So this, as I say, this is a policy from the Department of Health. We are merely the implementers of the policy. They are wanting to reduce costs, and they are also wanting to reduce costs, and by not having you do too many unnecessary tests. This group, perhaps through Anova, could share with you the circular that was published in 2017 by the Department of Health. This is one of the pages from that circular, and you can clearly see a glycated hemoglobin right at the top. So if it's a female, you can only ask for a glycated hemoglobin again after a month. For a male, it's 3 months. If you go to the bottom, say cholesterol, you can only ask for cholesterol again every 3 months. And it kind of makes sense. I mean, you do a cholesterol today, you get some sort of medication, and then you're not going to see a change tomorrow, next week, a month. You're going to see a change after 3 months. So there's some clinical input into these periods that were given for when to ask a test. And this is but one page. There are several tests, and as I say, viral load has got a 3-month period. And we can discuss a little bit more about that in the following slide. Now, specifically in the PMTCT, which is now called the Vertical Transmission Program, the old PMTCT, Prevention of Mother-Child Transmission, these viral loads are necessary. So here you want to ask for a viral load more often than not. Here you don't want the viral load to be rejected within that 3-month period. Here you could ask for it today and you could ask for it next week. In this instance, in order for the viral load not to be rejected, please write clearly at the top of the form, those 2 codes you can see at the top there, C#. I'm just wanting to get my little pointer going here, my laser pointer. C# PMTCT and or C# delivery. Of course, after the woman has been pregnant, after a certain period of time, she has to deliver. So the Department of Health looks at these stats and will get from us by punching in these codes into our LIS and data warehouse, C# PMTCTs. They can see all the pregnant HIV positive mommies. And then at some point, there's got to have to be delivery for that mommy. Sometimes the C# delivery is the one that's not done. So in cases of HIV positive pregnant mommies, if you're asking for their viral loads, please put on the codes C# PMTCT, C# delivery. This will override the rejection. So in this instance, you can ask for a viral load before the period that's normally prescribed for viral load, which is 3 months. There was a question from a PMTCT coordinator if delivery viral loads can be done prior to C-sections with other bloods. You know, one tends to overlook these sorts of things when it's a C-section delivery. And so, yes, it's completely acceptable to do the delivery viral load before the C-section. Many of the hospitals are doing viral loads for high-risk patients in the last trimester, and therefore they don't repeat that delivery. This is okay in terms of patient management. However, we would prefer that all patients get the delivery viral load at delivery in order to guide the infant prophylaxis. Got to know what the mommy's viral load was. When the baby comes back for a visit 3 days later, we know what the mommy's viral load. We can change the prophylaxis for the baby. Bottom line is, please remember those codes, C# PMTCT and C# delivery. If you're working with a clinic form, it's clearly indicated on the form. I just don't have a form here on this presentation now, but at the top it does say rejection code at the top, the third line from the top, and you put the C# PMTCT in there, and you put in C# delivery as well. I don't want to labor this point, but in an instance where you are, I'm just getting over here to the slide. In an instance here where you wanted to do a test, and you have looked back and seen that the test is going to be rejected based on the time period, but clinically the patient, in this instance here, I'll take an example of what's a good example here, for want of a better thing, an AST, or that's a short period of time. Let's say the glycated hemoglobin. You've done a good clinical study and you think glycated hemoglobin needs to be done, but it's not 3 months, hasn't passed in terms of a male. Then you can get an approver, normally the gatekeeper in your hospital. somebody who will approve that these tests get done. They give you an approval code. And again, the circular that you can get from Anova, or they can email it out to you, gives the format of that approval code. And when that's written on the form, it acts a lot like the CHPMTCT, and it will override the rejections. So all is not lost. I mean, you can still get the test done, provided you give us the right code. Then some of the rejections that we get are things like specimen unlabeled and form unlabeled, or form not filled in completely. Just very quickly, the kind of information that we need on a form for a patient, please give us the facility name and where you are, the hospital, clinic, and then service points. Now, I know clinics don't normally have ward codes, but they have an ARV club and they have other service points. So put that on there as well. Why do we need it? We want to communicate the results back to you. So we send it back to the hospital and specifically to a ward, and you will get the hard copy of the result right there. That's, of course, if you're needing it and we are printing it out for you. Then some information about the patient. We certainly need, as a minimum, patient's name, surname, and an ID number or folder number if you have it, as a minimum. Then more importantly, we also need the date of birth, the age, and the gender. Well, age and the gender, because there are age and gender-specific reference ranges that we would want to attach onto the result. So it's important that you put that on as well. And then in terms of babies, use the baby's own folder number. Too often we're using, for those HIV PCR, we're using the mother's folder number, and it leads to all sorts of complications. So this is baby's own folder number. And then, yeah, we got to match data to the correct patient. And then, as I said, age and gender adjusted reference ranges. So please put that on. Another thing that's important is collection date and time. Please put that on the form. Far too often we get specimens and we don't know when the sample was taken. Analytes aren't always very stable, and if we know the specimen was 3 days old, we might just want to reject it straight away just because it's too old. But if we don't have that sort of information, we process the sample, then find out that it's too old, and then we've just wasted money and time. And as I say, determine stability of the sample, and of course allows us to process the sample correctly for you. Yeah. Then you, as the person consulting and also perhaps the person taking the sample, put your name on, your SANC number, your MP number, a contact number. Sometimes we want to phone you and say, look, doc, your result is this, your result is that. Far too often we can't get hold of people with the results. And if you are writing, then write legibly. I mean, maybe you can make out what was written here, but I can't make out that little squiggle over here. If this result of these electrolytes were high of this urea, then I would not be able to call out this person. So write legibly, write clearly, give us the relevant information. It helps us in the lab. Then sometimes we get samples where the sample is inefficient, or you've used the wrong tube, or the sample is hemolyzed. I have a picture up here with an arrow with a circle around the syringe and the needle. Syringe and needle is fine in certain cases. The older people with difficult veins, sometimes you have to use a syringe. But by and large, make that your second choice. Make your first choice what is called a tube holder, or a barrel, or more commonly a bulldog, or even a varkie. So those are the more common names for this item, a tube holder, and then use that with a straight needle, and try and avoid the syringe. The syringe leads to hemolysis. Hemolysis, a viral load sample with hemolysis will get rejected. It'll get rejected because the iron, when the sample hemolyzes, it releases the hemoglobin. The hemoglobin is then in the plasma, and the iron from the hemoglobin affects certain PCR assays. So we don't want to use hemolyzed samples. It's going to be rejected. This is the way we would like for you to take a sample. Straight from the arm, this is going into your vein, straight onto the barrel. The tube goes back to the barrel, so it goes from the arm straight into the blood tube, rather than from the arm into a syringe. You put the syringe down, you tend to the patient, wrap the patient up, discuss things with the patient, sample is still lying and clotting now in your syringe, and then you decide to take it from there to put it into your tubes. If you are going to be using barrels, those of you who are using barrels, thank you very much, but I don't know if you can see this very clearly. This is from a study, and if you look at this barrel over here, those are little drops of blood, and that's clearly blood stained at the top here. These are single-use items. If you are going to wash them, if you're wanting to make them reusable, then make sure you wash it correctly. These again were blood drops, and you can always go and have a look at this paper around reusable blood collection tube holder as a vehicle for transmission. So as I said, hemolysis affects samples were rejected due to hemolysis. It affects the PCR, some PCR assays. And so how can you prevent hemolysis from happening? Firstly, don't use a syringe and a needle if you don't have to. If you are going to be using a needle, use a bigger gauge needle, because using a small gauge, you're forcing the red blood cells through that very small gauge needle, and you are rupturing the red blood cells. Also, you are pulling back, and others are pulling back very hard on the plunger to get the blood out. Then when you have the blood in the syringe, then you are putting it back into the tubes, and here too you are pushing on the back of the plunger back into the tube. My suggestion here is that if you have to, under certain circumstances, take blood in a syringe with a needle, and you are wanting to put it into the tube, let the vacuum of the tube draw the blood. Or to start off with, draw up quite slowly so you don't rupture the cells, and when you are putting it back, let the vacuum of the tube draw the blood out of the syringe. And also, don't hold, I had a nice picture of this for these medical students about how to prevent needle stick injuries. So I'll just make a little tip for you. Take your tubes and put them flat on the table, and then guide your needle into the rubber stopper, rather than holding the tube in your hand and guiding the needle to the rubber stopper. If that needle slips, you've got yourself a needle stick injury, and it's something that's so easily avoidable. And then other causes of hemolysis: don't expose your specimen to heat or cold. That means not putting the specimen into a freezer or directly onto an ice brick. And when you are cleaning the patient's arm with alcohol, as my colleague Sister Thompson always says, and she does this quite often, cleaning a patient's arm with alcohol. Some patients need quite a bit of a wash on the arm to get the arm really clean. You could be using quite a lot of alcohol. Let the alcohol dry. If you put alcohol onto a blood sample, it's going to rupture the red blood cells. You don't want to, as you stick the needle in, stick some alcohol in as well, and then hemolyze the sample. So try to prevent that from happening, and so let the alcohol dry. Then wrong collection tube. There's a specific order of draw that has to happen. You can't take the purple top tube first, then a yellow, then a blue. There's a specific order. It's always this one first, then that one, and that one, because it can lead to possible contamination. All the tubes contain additives, and you could be contaminating one tube from the previous tube's additives. And some of these additives, like the electrolytic additives, like the dipotassium EDTA or the sodium fluoride and the potassium oxalate, those could contaminate the next sample. So there is a specific order of draw. For example, there's an example at the bottom. If the additive in the purple stopper tube contaminates the green stopper tube, this could falsely decrease the calcium and increase potassium. I'll give you another example. The purple top tube contains potassium EDTA. If you were wanting to do some electrolytes and a full blood count, for example, I'm diverting a bit from viral, but I've got another slide on this afterwards as well. But if you are wanting to do some electrolytes and a full blood count, if you took the full blood count sample first, the purple top tube that contains dipotassium EDTA, it's quite possible that you can contaminate the back of that needle in the barrel with the yellow stopper. Then when you're wanting to do the electrolytes in the yellow stopper tube, that's been the potassium could possibly be falsely raised because of the contamination from the EDTA. So there is a definite order of draw, and here is the order of draw. So always a sodium citrate first, then the SST, the clotted sample. Then if you were doing heparin, a green top tube, then you do your EDTA, then your viral load sample, then your sodium fluoride and potassium and sodium fluoride and potassium oxalate for your glucose samples. So I could let you have this. It's also available on the web. I would suggest go to the web, download it, stick it on your phone, make it a favorite, so you'll always know what the correct order of draw is. Sometimes, and this is what happens when you're taking with a needle and a syringe, people tend to take the caps off the tube to put the blood from the syringe in the tube. Look what happened here. This is a purple top tube. This is a purple tube containing potassium EDTA. It normally has a purple cap or lavender cap. They swapped the caps around, so this has now got a yellow cap on a potassium EDTA tube. So I'm wondering, where is the lavender cap? Is that on the other yellow clotted blood tube, thereby contaminating that sample with dipotassium EDTA and elevating the potassium that could lead to a hypokalemic patient being reported as normal for the potassium? Those are the consequences that you get. Do not take the caps off. Do not remove the rubber stoppers from the tubes in order for you to take your blood-filled syringe and fill the tubes. Rather use the barrel and a needle, and that way this sort of thing won't happen. Yes, am I done?
5 minutes.
5 minutes. Okay,
Thanks
just
so
quickly, a lot of those samples, some of the rejections said the quantity of the samples was not sufficient. You're sending us too little blood. So this, if you can see this, these are the lines on the fill lines on the tubes, and try to fill to these lines. We need at least 4 to 5 ml of blood in this tube. We need full tubes. This is not a great picture, but this is the kind of thing that you're sending. This are the 5 tubes that recently was sent to a lab, and after I'd taken this picture, we centrifuged them. So in this second tube, what you thought was a lot of blood actually only produced that amount of serum. What looked like a lot of blood, that's just scraping on the side, very little amount of serum. So this guy did the right thing, filled the tube to the full line, and you can also, and you've got a good sample. And also you can see this guy struggled a bit to get this very little amount of blood. And there's a bit of hemolysis in there as well, which could affect some of the tests. So what we ideally want is for the tubes to be filled to the line. Do not underfill the tubes. Do not overfill the tubes. How do you overfill a tube? By taking it with a syringe, taking the cap off, squirting the blood in. You overfill the tube. The cap doesn't fit. It pops up during delivery to the lab and the courier picks it up. It's important that you mix samples correctly. Too often we get these EDTA samples that are clotted, the purple top tube. It's like sugar in tea. You've got to stir it properly. This is a case of putting blood in the tube and mixing it properly. And if you have one of these charts, they clearly show on the right-hand side there the number of inversions. If you look at a purple top EDTA tube, it's about the most. You're going to have to stand there and shake it 8 to 10 times. And one shake is an up and a down. So make sure that you mix the samples properly. Then labeling. Far too often we get samples that are not labeled or mismatched samples. So this is of the samples. That's what needs to be done. Is okay. Do not label the stoppers. Don't put your stickers on the caps. When we take these caps off, gone is the identification. There's an automatic robotic arm that comes and takes the caps off and throws it into a bin. I wouldn't know the identification of that sample if you put the label on the cap and not on the tube itself. And then this is also what we don't want. I mean, if you didn't have enough stickers, just write on the tube, but don't stick 3 tubes together. Don't stick the label over the cap. We can't take it off. Don't cover the barcode with a sticker. We can't read it with our barcode scanners. These little wings on the side, they don't fit very neatly and comfortably in our racks that we put on the machines. So this is what we don't want. There was something else I wanted to mention about the labeling now, which I forget. I wanted to mention information doesn't match. So I wanted to go to the top quickly. And this will be my last LC. I just wanted to get back to the here. This one here, information doesn't match. That's when the form says John and the sample says Peter. Specimens that are not labeled, you just haven't stuck anything on the specimen. We're not going to do it. We're going to reject it. Require PPT sample. You've given us something else. It's insufficient for a rerun. You see, the problem is here. We did the sample. We're concerned about the result. We wanted to rerun it. We couldn't. this business about the information doesn't matter. Just a quick tip, and it's my last thing, and then I'm gonna sign off. Sometimes when the stickers are in the folder, the patient stickers are in the folder, make sure that the stickers that are in the folder are the ones that belong to that patient. Far too often I have seen a data clock print a set of stickers, pull them off, but leaves one or two behind of that patient. Then she prints another set of a different patient, and those two of the previous patient ends up in the folder. You are not looking, you're just taking off stickers and you're putting them on, and that's how Peter happens to be on the specimen and Paul happens to be on the form. We are going to reject those specimens. I hope I've helped a little bit. Elsie, I'm done. You can take over, please.
Lovely. Thank you so much, Akshan. That was very, very interesting. Definitely a change of pace for us from the previous echo. So very, very practical. Maybe some feedback from the participants. What did you guys think? Louise.
So much, Ishan. It was a great talk. And I'm sorry for all the trauma that we put you through as clinicians. I just wanted to ask for children, especially for neonates or little babies, we sometimes take, we have to drip the blood into the tubes. So in that instance, do you have any tips as to how we can do it properly without making a sample hemolyzed or something like that?
Well, I don't know about not hemolyzing it. I mean, you're going to have to take the right lancet and the right depth to get that drop of blood. But then when you're scooping up and you've got that first drop of blood sitting on the lip of that scoop, take the sample and tap it, the microtainer, and tap it gently onto a hard surface. That will push the drop to the bottom, and it also allows a certain amount of turbulence in the tube that lets it mix with the anticoagulant that's in there. When you're done with that first tapping, take the second drop, do the same thing, third drop, tap, and then collect it between 400 and 500 microliters. And then at the end, when you put the cap on, there's no harm in just tilting the specimen upside down. That too, we find too often that for those HIV PCR samples, that the samples are clotted, and it's just because it's not mixed properly. But yeah, from a phlebotomist at New Somerset Hospital, this tapping of the sample, once the drop is sitting on the lip, tap the sample, the drop of blood drops to the bottom, then collect your next one and tap, and that allows for mixing and for the sample to go down to the bottom.
So if I could just ask a follow-up, if we don't have microtainers, if we only have the normal sized tubes, which might not be such a huge problem in the Western Cape, I'm not sure, but I'm based in Johannesburg. Is there a way that the lab could still process the specimen, even though the amount of blood might be very small in a normal container? Do we have to alert the lab to that? Or is it a problem because of the amount of additive that's in the container that it can't be processed if there's only a very small amount of blood?
Yeah, so one of my slides that I had, they did say you've got to have the right amount of blood for the right amount of additive in the tube. So you always have to fill the blood to the full line, because then the ratio of additive to blood is right. Now, I know that we do, I think internally we have pediatric tubes. So we have small purple top tubes, much like you have the adult size tube. We have, not the microtainer, the adult ones, but in a smaller volume. I don't know how available that is from your stores, but it's something that you could look at. But yeah, I wouldn't want you to be filling up an EDTA tube with like 5 ml of blood from a kid only because you want the ratio of additive to blood to be right. It's not conducive. So perhaps you should explore the idea of using the smaller pediatric tube, not the microtainer, the pediatric tube. I think it's about 1 ml of blood that you can put in there. But why are you running out of stock?
Okay, perfect. Any other questions? Louise, I'll leave you with that difficult management question for you and Akshan. For us here, any other questions on Sean's really good presentation and on Crystal's presentation and CLI in general. Okay, then I'll hand over to Samantha. Samantha is going to do a very quick overview for us, and then also open up if there's any other questions regarding to some of the other sessions broader. Samantha, I'll hand over to you.
Thanks, Elsie, and thanks, Iksan, as well for the presentation, and Crystal for joining us today. I think it was actually a really good addition to the echo sessions as well, because we haven't done one like this before. So I think it was nice to just gain some practical knowledge and some clarity on some of the things as well. And I think the questions that you asked, Louise, are really pertinent. Might not be for Cape Town specifically, but thank you that you opened up some of those questions. I think one question that I had, Ihsan, I don't know if you're still open to answering questions, is probably more from a post NHLS sort of shutdown perspective. I know that some of the tests that were requested during that period is registered on NHLS, so we have access to actually see that it was done, but the results are not available. How long should we be waiting before we have to repeat the result if it's a viral load that's urgent, or if it's a PCR that was done? Maybe you could just give us a bit of clarity with regards to that.
So I can't give you clarity. I mean, I keep hearing, I'm now not the IT person, but I hear some talk in the corridor about how we're struggling to get the results now sent up to, not I don't want to use the word struggling, but we are now trying. We've registered the backlog of samples. As you say, you can see them, and now we have to match this large database of results to patients, and it's taking time, and I can't give you an answer. I don't know when. But I mean, I haven't been at the office for the last 2 or 3 days. I can find out from you, Samantha, and perhaps reply to you, and you perhaps answer to this group again. So at this stage, I couldn't tell you.
Okay.
I don't know.
Okay, awesome. Yeah, it would just be nice to just get some feedback, like even in the week or next week or two, just with regards to guidance, because obviously some things are a bit urgent, like especially in our pregnant population, if they are pregnant or breastfeeding, and we need sort of that urgent viral load to be able to either adjust management or change certain things, then obviously that does impact our ability to do so. So it would be nice to have some feedback in the next week.
I will give you some feedback and copy in Crystal as well.
Thanks so much. Louise, I see a hand.
Yeah, I just wanted to say, in terms of that issue that Samantha's talking about, where you can see the result on WebView, but there's no report that's available. Will those results be processed at some stage, or is there a risk that in a couple of months' time we would still not be seeing the result? Is it just a case of waiting until the result is there, or have some of those results been lost in this time period?
So no results have been lost. I mean, I was following the process all the time when specimens were coming in, and those results are sitting somewhere on an Excel spreadsheet. At some stage, we were sending out here in the Western Cape anyway. Specimens were coming in, they were being registered on an Excel spreadsheet, and then we'd wait until the results are available on an analyzer, and then we'd take the result from the analyzer, copy it onto the spreadsheet. So there were these huge Excel spreadsheets with data on them. The important part now is correlating that data with the patient's data. Once you register the patient on our LIS, then you have to upload the result to that patient and make sure that it belongs to that patient. I think that's the issue that we're sitting with at the moment, is just getting that part right. But no tests were not done. As far as I know, all HIV, all viral load samples were done, and they're sitting somewhere on an Excel spreadsheet that needs to be uploaded onto WebView or onto our LIS system. Yeah.
Thanks so much, Ishan. I think that does answer your question quite nicely, Louise. But again, we'll await some feedback, and we'll try and share it with you as well in Joburg. And then with regards to the echo, thank you so much for everyone that has joined and everyone that's managed to join for the last 7 weeks. Even I missed a session, sorry, I had another engagement. So if you have managed to join for every single session, well done. You will receive a completion certificate from the iEcho platform. And then we will keep you updated with regards to CPD as well. And then just in summary, in terms of the high viral load management, I hope everyone has learned something, even if you've been listening a little bit in the background and not really asking any questions. We are also available to you if you need to ask any questions. If you don't know who some of the clinical advisors are at Anova, you can just find out from your facility if that is so. But we are available via email. Our emails are actually on the Echo platform as well, if there's anything that you want to contact related to high viral loads as well. And I think the most important take-home message in terms of the management of clients with high viral load is really that one shoe doesn't fit all. We need to address the barriers to adherence, and we need to identify them early. And you're not alone on an island. There's always someone that you can pick up the phone and ask if you are unsure about how to manage high viral loads. We also do need to keep in mind our low-grade or low-level viremia patients as well. So if they have more than 2 low-level viremia, so that's between 51 and 999, we should be monitoring those category of patients closely as well. And then if you also are unsure whether or not someone is resistant and they've been on treatment for long and you've addressed a lot of the adherence barriers, also don't hesitate to actually approach the third line committee and ask, is this a candidate that is appropriate for resistance testing or not? Thank you again to everyone and to the panel team as well, who've been involved for the last 7 weeks. And obviously to our subject matter expert, thank you so much. We really do appreciate you taking the time to actually join us and to do the presentations as well. If there aren't any other questions or any other comments, you can sign off. And then the last request is that if you do have any feedback that you would like to give on the last 7 sessions, that you please do so. You can do so on the iEcho platform, or you can send us an email with feedback as well. Thank you so much.
Perfect. Thank you so much, everyone. I think that is the wrap.
Bye.
Thanks again, Ishan. Thanks again, Crystal, and thank you as well, Dr. Sam, Dr. Cindy, Dr. Louise, and our colleagues that we don't have here today. Thank you so much for all the hard work over the last 7+ weeks, Sister Estelle in her absence as well. It's been an honor to do this project with you, and to the next one. Thanks, everyone. Goodbye.
Thanks. Bye-bye.
Thanks. If you could just stop the recording.